Now let's talk about DSC imaging, where on the contrary, it's not T1 weighted, it's a T2 star weighted sequence. The principle is that when the contrast agent gets in the vessel in a certain voxel, there is a concentration difference of contrast agent between the vessel and the tissue. This generates a susceptibility gradient. So chi1 is in the vessel, chi2 is in the tissue, and we call delta chi the difference in the susceptibility gradient, which causes dephasing, and because the contrast agent is paramagnetic, so it causes a reduction in the signal locally. So you can see that when the contrast agent gets to the tissue, the signal becomes lower, and then it goes back to baseline. Okay, so if we plot the signal intensity curve, the time intensity curve looks something like this. When the bolus of contrast arrives, there is a transitory dip in the signal that goes back to baseline approximately. Um, so so first of all, contrarily to DCE, DSC must have a bolus of injection. It has to be injected at high rate in the blood flow, the contrast agent I'm talking about. 4 milliliters per minute is the guidelines, because we need a lot of contrast agent compartmentalized inside the vessel to generate this gradient of this susceptibility gradient and get an actual good dip in the signal. Why? So you remember, like, if this was a T1 DCE, we would see a change in the signal due to the contrast agent that goes up and then stays up. Why does this go down and then doesn't stay down, but it goes back up? The reason is that this gradient of susceptibility happens only when there is a bolus. So if the well, let's leave it as it is for now. So in order to do a DSC perfusion analysis and get ultimately to CBV, we convert this signal intensity, so this time intensity curve, into delta R2 star over time, so the change in transverse relaxation time, which assumes no T1 effects. We'll get to that in a second. And then so this is delta R2 star over time, and then the area under the curve of this spike is proportional to CBV. We'll get to that in a second too, and we'll explain that better. So ultimately, the idea is that we get CBV maps that are proportional, or RCBV maps, relative CBV maps, that are proportional to this area under the curve. There are two assumptions, at least theoretically. One is that there is no leakage of contrast agent. So quite the opposite of DCE. We are assuming that all the contrast agent that we administer to the patient stays in the vessel and creates this gradient. And the other assumption is that there are no T1 effects. In fact, to estimate delta R2 star directly from the signal intensity of a T2 star weighted image, we are assuming that there are no T1 effects. Instead, there are T1 effects in these sequences, which means that this is a T2 prevalently T2 star weighted sequence, but it has some T1 weighting in it. And the fact that this assumption also is violated does cause some problems, as we can see later. Long story short, this is called a perfusion imaging, not a permeability imaging, because the numbers that we calculate have to do with this area under the curve that has to do with how much contrast is in the vessel. So it tells you how many vessels are in the voxel, whereas DCE told you how much of a leakage from the vessels to the tissue we have. So that's why that was called permeability imaging. This is called perfusion imaging. So let's see a little bit of technique, because it's important to understand a couple of concepts. So first of all, CBV, in terms of absolute CBV, is quantified in milliliters per 100 grams of tissue, and the original formula is the following. So the integral under the curve of the concentration time curve in the tissue, which is derived from delta R2 star, and Ca over time, which is the AIF derived concentration. So originally, the idea was to quantify absolute CBV in milliliters per 100 grams of tissue, and we needed an AIF, which is problematic, as we said. Pragmatically, we don't do this anymore. What we usually do is we calculate delta to star over time from a single echo, as we said. We'll talk about what multi-echo is later, as with this equation. And then the integral under the curve that we showed, so the area under the curve, is proportional to the absolute CBV. That's why we call it relative CBV. So relative CBV means not absolute CBV, means a metric that is proportional to CBV. And it is not expressed in milliliters by 400 grams of tissue, it's in arbitrary units. If we look at this RCBV calculated from a delta to star over time curve, we can see that the RCBV measure is going to be probably around 100 something, let's say 120, right? Because at any given time is 12, then it's 10, then is 6, then is 4, whatever. And if we do the integral, if we calculate the integral and we calculate the area under the curve, it's probably something around, let's say 120 for simplicity. You never see 120 RCBV in an article. This is why the measurement is usually normalized to the white matter or another reference tissue or something else. So this is why we usually use normalized CBV or normalized relative CBV, or sometimes in the articles you will still see RCBV, meaning that it's relative to the white matter. But I do want to point out that the relative in RCBV historically is not it doesn't mean relative to white matter. It means relative because it's not absolute. Anyways, long story short, we usually normalize to some tissue and we report a normalized value. So if this was 120, the whole integration of the curve, but the white matter has 60, this would be a voxel with RCBV and RCBV 2. 120 divided by 60. So just to confirm that I am not making up things, this is a very important, well-written review article of the technique. And we can see that the CBV is derived from the area under the curve without the arterial input function, just straight out of the measurement, or at least the time concentration curve, which is essentially delta R2 star, or at least proportional to delta R2 star. That's why we usually calculate directly from delta R2 star over time. Whereas the arterial input function we only need for CBF and MTT, that are more maps that we use in neurovascular studies rather than neuro-oncology studies. However, we will see in a second, unfortunately, that the arterial input function that we just said we don't really need for relative CBV, we actually do need at the end of the day. We'll see in a moment. I want to speak about leakage effects. So we said that one of the assumptions are that there is no leakage, whereas we know that unfortunately there is leakage in enhancing tumors. And the other assumption is that there is no T1 effects. Both these assumptions are violated and cause a lot of interesting effects. So first of all, we see that when there is leakage, two things can happen. So if there was no leakage at all, probably approximately, let's take this with a grain of salt, but approximately the time intensity curve would create a drop and then go back to baseline approximately. If there is leakage, two things can happen. Either there is T1 effects, so T1 leakage effects, and the curve creates a spike above baseline. Or there are prominently T2 star effects and the curve remains underneath baseline. The reason why either or happen are very complicated, it has to do with tissue factors in terms of how much permeability the vascularity has, how much extravascular space the voxel has. But long story short, we've learned in time that some different tumor types show a different profile of this curve. Like GBM can do a little bit more of T2 star leakage effects. Lymphomas can do a little bit more of T1 leakage effects. So some of these tissue factors cause the curve to be a little different in different tumor types. I want to point out, I'm calling these leakage effects for simplicity. But I actually chose that I really like it more to call it post-bolus effects. The reason is that for sure some of these residual T2 star effects are probably almost definitely from residual contrast agent inside the vascular space. So if we call it post-bolus effect, we include both the leakage post-bolus effect and the still in the vascular space post-bolus effect. Anyways, we know that glioblastomas do more of T2 star leakage effects and meningiomas do. Lymphomas can do more of T1 leakage effects. And we calculate this as a semi-quantitative metric that is called percentage of signal recovery. So what is the percentage of the recovery of the signal after the bolus? In this case would be around, I don't know, 80% probably. It would be 100% if it goes back to baseline, whereas here is above baseline, so it's probably 130% or something like that. So this is a PSR map because we have one value per voxel, we can map it in 3D. But one very important aspect is that when we change the acquisition factors, in this historical example, the preload, we change the shape of the curve and we change the PSR. So this is the same tumor first acquired with a certain protocol and then with the same protocol, but after preload. Preload means that I'm injecting contrast as a preload, and then I'm waiting, and then I'm actually performing DSC with a second bolus. Okay, so before preload, the PSR was much above 100%. You can see. After preload, second injection, the PSR is much lower than 100%. See, it's red here and it's blue here. And it's the same tumor. So acquisition factors highly impact the shape of the curve and leakage effects or post-bolus effects. You should remember this because we often say in the clinical practice also that we can look at the curve and get some sense of what type of tumor it is. It's true to some extent. It's true if all the acquisition factors are kept the same. So if you have your own experience of your sequence and you've seen 100 cases and you know what the curves look like, yes. But if you want to compare to, let's say, a certain article that you find in the literature for which you're seeing the shape of the curve, not necessarily you're allowed to do that. You have to check that their post-sequence parameters are the same as the ones you're using, which is almost never the case. So let's be cautious about that. So we said there is leakage, and historically the problem was more of a T1 leakage effect because historically people would use very T1 strong sequences like high flip angle and so on. So, but this is not even that important. The important thing is that there's been a mathematical leakage correction that's been proposed. The first and historical one that most clinical software products have is the Boxerman-Schmainda-Veskov leakage correction that you can see here that the uncorrected version shows T1 leakage effects, whereas the corrected version brings up the delta to star curve and it's corrected and it doesn't show these T1 effects due to possibly extravasation of the contrast agent. What I want to point out is this has to do with the T1 effect and it creates this nonsense of the delta to star curve becoming negative, so underneath zero. This makes no sense that the transverse relaxation rate over time changes and becomes less than baseline. It makes no sense because this is a change in contrast agent concentration. So think about you have zero contrast and then you inject the contrast, you have this contrast over time curve and the contrast concentration becomes negative. The concentration of a compound in a voxel can never be negative, of course. Well, this is not the concentration, this is delta to star over time, but it's supposed to be proportional to the concentration. One last comment would be that the problem is that this is not the real delta to star. This is a delta to star calculated from a single echo DSC that has T1 effects. So this is the mathematics of the leakage correction that we're not going to discuss in detail. But what's important to understand is this item. To perform the leakage correction, we again need the arterial input function. So we thought we got rid of the arterial input function to simplify the relative CBV calculation, but unfortunately we're back. We're back and we're again forced to use arterial input function to perform leakage correction. So this is an overview of DSC metrics. These are CBF, CBV, MTT, a lot of metrics that are usually used in neurovascular studies. But for neuro-oncology studies, for brain tumors, we usually use RCBV leakage corrected, or better, NRCBV leakage corrected. See this case also where there's a lot of T1 leakage. If you calculate RCBV straight out of delta R2 star with no leakage correction and no AIF, you get this falsely reduced CBV, whereas after leakage correction, you see how there's a lot of actual CBV elevation within this lesion. And the other map that we talked about is PSR, for which we actually quantify to some extent these T1 leakage effects compared to the baseline, and we calculate the PSR, which is in this lesion would be 100, I don't know, 120% or something like that. So maybe it's clear, maybe not. There is some conflict in whether or not we want CBV or PSR from a DSC study. The reason is that according to guidelines, we are trying to optimize CBV optimized DSC sequences to have as little as T1 sensitivity as possible. Why we said before that one of the assumptions is that there is no T1 effects when we calculate CBV. So to make this assumption as true as possible, we have to reduce the T1 sensitivity. How do we do it technically? We lower the flip angle to 30, 35, or we lower the flip angle to an intermediate level of flip angle 60 to 65, but with preload. And in addition, we also have to use leakage correction to correct for leakage. Whereas for PSR, if we want to see PSR and we want to see these changes of the percentage of recovery over time and to differentiate different tumor types that show different recovery, we want to be sensitive to T1 effects. So for instance, we will use a high flip angle of 90 with no preload. So there is some conflict because if we want to optimize DSC for CBV, we cannot optimize DSC for PSR, so we have to make a choice. You could say, why don't we just quantify the percentage of signal recovery on a CBV optimized DSC curve? You could do it, but literature shows that it may not be useful. Like for instance, in this article, they saw how glioblastoma and lymphomas showed the same PSR after preload. Whereas if you don't use preload, so you are more sensitive to T1 effects, then you do see the difference between the two groups. Let's go to clinical applications very quickly. Differential diagnosis is a